Okay, so there. Alright, so when we push a probe through here, okay, there, we turn it over, we can look into the interior of the skull and see the probe there. There. So see the probe right here, okay? So there, if you look in the posterior cranial fossa, okay, so we can admit it here, turn around and see it there. Okay, so I can take it out there. Alright. So this is indicating what? What is that indicating? What is this opening here? Alright. So when present, it's occupied by the largest emissary vein. Okay? Emissary veins, because of the negative pressure within the dural sinuses, superficial blood that are in veins outside are drawn in through these veins that are called emissary veins. Emissary veins connect the superficial veins of the scalp with the deep dural venous sinuses. And one of the largest ones to occur, as we can see, quite large here, that is the condylar emissary vein. And that passes through the posterior condylar canal, or because that's the only thing that passes through it, it's called a condylar emissary foramen. Okay, so that's the posterior. Okay, and that condylar emissary vein will drain into the sigmoid sinus. Okay, so right here you see the entrance on both sides. It's very, very large right here. See there, very large right here, there. So there you can see the condylar emissary vein will go through that opening to enter into a sinus that makes a S-shaped bend and comes around here, and that's the condylar. So the condylar emissary vein will drain into the sigmoid sinus, okay? And we can see the sigmoid sinus leaving to become the internal jugular vein to lead through the jugular foramen, okay? This is from a previous exam, okay, and that's a Petrous temporal bone, and there we're looking now at the superior petrosal sinus. So running along the Petrous temporal bone here, making this groove in the bone will be the superior petrosal sinus. So the cavernous sinus, which is lying right here, is drained primarily by the superior petrosal sinus to the inferior petrosal sinus. And we can see this groove. You see that groove there? That groove is made by the internal carotid artery. So the carotid artery begins between C3 and C4 and ends at the anterior perforated substance. Has a cervical part, has a Petrous temporal part, and emerges right through here and then makes a bend right in here, and this area will be occupied by the cavernous sinus. Okay, so the cavernous sinus is right here. And we can see when we continue, so that's the cavernous sinus will be on the side, and it's drained primarily by the superior petrosal sinus, okay, and seen on this skull very well, traveling along here, will be the inferior petrosal sinus. So in that groove right along the side, very prominent in this individual, is the inferior petrosal sinus. The inferior petrosal sinus is one of the structures to drain through the jugular foramen. Okay, so cranial nerves 9, 10, and 11, the internal jugular vein, and the inferior petrosal sinus drain through the jugular foramen. And when we look for the jugular foramen on a wet specimen, we would expect to see also going through there the spinal root of the accessory. Okay, there you can see the internal acoustic meatus right here, quite clear. Okay, for the nervus intermedius, together with the cranial nerve 7 and 8. Nervus intermedius being a part of cranial nerve 7. Situated also right at the fundus of the internal acoustic meatus is the ganglion. Very good. And that's the ganglion of Scarpa, or the vestibular ganglion. Okay? So there's a thing called neurofibromatosis. There's a type 1, type 2, and one of them manifests themselves as a schwannoma of the acoustic nerve, And many times we will see on the patient, not uncommon to see an acoustic neuroma, okay? So an acoustic neuroma right here, okay, right here, and can become very large, and will affect the vestibular cochlea and the Brinstein artery, etc. The Brinstein artery will go through this opening. So there we find now the superior petrosal sinus, the inferior petrosal sinus, and the internal acoustic meatus. There's our old friend, the dorsum celli, with the clinoid processes. There is a lesser wing of the sphenoid, and along the lesser wing of the sphenoid, we will find the sphenoparietal sinus. Okay? The lesser wing of the sphenoid will have the sphenoparietal sinus, which will drain to the cavernous sinus. And right here, that area is known as the jugum sphenoidale. That's the jugum sphenoidale right here. Okay? Going forwards, we see the crista galli, which will have attachment of the falx cerebri, and we see also the cribriform plate. Resting on there are the olfactory bulbs, and we need to know about the cranial nerves. Very important, in those nerves we'll find the bulb is the mitral cell. Remember, the two olfactory bulbs are connected through the anterior commissure. Two olfactory bulbs or two olfactory tracts, the olfactory receptors are connected through the anterior commissure. The olfactory tract divides into medial and lateral olfactory striae, and the medial olfactory striae, some will go to the septal area, and then others will enter the anterior commissure to go back and recurve around, so we get what's called contralateral inhibition. Okay? Alright, so that's very important. Okay? There is the apex of the Petrous temporal bone, and traveling right in relation to the apex of the Petrous temporal bone, right through here, that will be cranial nerve 6. That's the abducens. So the abducens will pass right through here. Okay? There's a clivus. Okay, so we find the vertebral arteries uniting to form the basilar artery, and these will be traveling up the basilar artery, will be on the clivus right here. Okay? We turn the skull over, we can put it in an opening going this way. Alright? And that opening going there is the musculotubal canal. Okay? The musculotubal canal, remember, will transmit the eustachian tube and the tensor tympani. The eustachian tube and the tensor tympani will travel through the musculotubal canal. And very prominent here is, let's look on, very prominent, when we use this skull, very prominent here is another opening. So we see the jugular foramen, the external opening of the carotid canal. The stylomastoid foramen is there. Foramen ovalis right here. And then just beside the foramen ovale, in relation to the spine of the sphenoid, right here is the foramen spinosum. And foramen spinosum, recall, has everything to do with the dura of the middle cranial fossa and the overlying bone. The nerve going through, nervus spinosus, a branch of the mandibular division of the trigeminal, and the artery, middle meningeal artery. The middle meningeal artery, very important in relation to this H-shaped suture right here. We see an H-shaped suture right here, and you see it's marked in all the exams, it's usually there. Okay, and that's the pterion. Okay, and the pterion is where we find the anterior branch of the middle meningeal artery. Okay, and this bone is very thin around here, and if fractured, may lead to an epidural or subdural hematoma, which if it compresses Broca's motor speech area, will give you, as we know, as a motor aphasia. Okay, right here. So, and that pterion overlies a point on the brain known as the Sylvian point. Known as what point? The Sylvian point. Alright, that's where the stem of the lateral sulci divide into its branches. Okay? Alright? And here we see an opening right here, just in relation to the triangular McEwen. Let me see it better over here. Alright? And traveling through there is the auricular branch of the vagus. There we see the Petrous fissure, and that Petrous fissure has going right through there, as we know, the chorda tympani. The chorda tympani goes right through the Petrous fissure. That's the chorda tympani. Okay, you can see right here very clearly, and this is double in the skull. Okay, and that's for the tympanic branch of glossopharyngeal. So that's Jacobson's canal or Jacobson's nerve. Okay, so that nerve is a branch of the glossopharyngeal and will lead up into the tympanic plexus. Okay. Lastly, on the skull, this is a very important foramen, and that's the stylomastoid foramen. Lies posterior lateral to the styloid process. And passing through there will be the facial nerve. Okay? And the facial nerve, before emerging through the stylomastoid foramen, will give 4 branches. And what are those 4 branches? 1, the chorda tympani. 2, the greater superficial petrosal nerve. 3, the nerve to stapedius. And 4, the branch to the tympanic plexus. So the facial nerve, where's the nucleus of the facial nerve? Kelly Monroe. Very good. Kelly Monroe, where is the nucleus of the facial nerve? In the tegmentum of the pons. Reasonable? In the tegmentum of the pons. Nuclei would include the main motor nucleus. There's a sensory nucleus. There's a special sensory gustatory nucleus. That's the nucleus of tractus solitarius, will serve that function. And there's a parasympathetic nucleus known as a superior salivatory nucleus, which has a little bud off of it called the lacrimal nucleus. What are the nuclei of the facial nerve? Where are they located? In the tegmentum of the pons. There is a main motor nucleus controlling the muscles of facial expression. We have a nucleus which regulates nearly all the secretomotor activity of the head, with exception to the parotid, and that's called the superior salivatory nucleus, which has a little bud coming off of it called the lacrimal nucleus. Okay, then we have associated with a sensory nucleus of tractus solitarius, and a little normal general sensory. Okay, very important is the motor nucleus and salivatory nucleus and taste for the anterior 2/3 of the tongue. Just remember that in the facial nerve you may have an upper motor neuron lesion or a lower motor neuron lesion. How do you distinguish the two? Lower motor neuron lesion is from the nucleus itself. Remember that nucleus is going to send fibers that wind around the what? The abducens to form the facial colliculus. So a lower motor neuron lesion, like we see in a Bell palsy, that side of the face will be affected. The whole half of the face. Alright, so you'll be unable to raise the eyebrow, nasolabial fold will be, crease will be gone, drooling, unable to close the eyelid, so they have to put a black patch over you, look like a pirate, so that your conjunctiva doesn't dry out. Okay, so you get a half of the face. Okay, so not a nice thing to wake up one morning with a Bell's palsy. Okay. If you have an upper motor neuron lesion now, what do we see? That the opposite side of the lower side, the lower half of the contralateral side of the face is affected. Now, upper motor neuron lesion, lower half of contralateral side. So the nasolabial fold is gone, crease is gone. You may get drooling, the lower half of the face. And if you smile, the lips go to the opposite side. Okay? So distinguish an upper motor neuron lesion from a lower motor neuron lesion. Okay? So the facial nerve. So the facial nerve goes through the internal acoustic meatus with the nervus intermedius. And then prior to coming out through the stylomastoid foramen, we said gives 4 branches. 1, chorda tympani, which serves for taste and secretomotor to submandibular, sublingual and glands of the anterior 2/3 of the tongue, that's chorda tympani. Greater or superficial petrosal nerve on its way to the pterygopalatine ganglion. Nerve to the stapedius, so you get hyperacoustics in a facial nerve damage. Everything sounds loud and deafening. And then now a branch to the tympanic plexus. Okay, all of that is going to come from the facial nerve. And remember there again, once again, when you see the going to the exam and the point is placed diagonally, it's going into the musculo-tubal canal. Okay, all right. So we can leave skull alone. So that's skull. Okay, there's much more to say on the skull, but I think we have pointed out most things. But the examiner, if he's kind, all right, will throw in a foramen ovale. It's a kind examiner. JP, speak to those examiners. I won't be there. All right? If you're kind, they will throw in a foramen ovale for you. Okay? And the foramen ovale is a nice one to get. We know what goes through there. Male. All right? So the mandibular division of the trigeminal, A, accessory middle meningeal artery, which is supplying the trigeminal ganglion, L, lesser petrosal nerve, which is on its way to the otic ganglion, and E, emissary veins. Okay? Right? Male from foramen ovale. Right beside him we said is foramen spinosum. Remember, middle meningeal artery from the maxillary, nervus spinosus from the mandibular division of the trigeminal. Okay? Alright. End of that. Alright, so let's move over right here. Now, Dr. Laws asked me, GP, can I just have that one first? Dr. Laws asked me to show you, I wasn't planning to show you the spinal cord. So he just rushed in and said, oh, the students had not seen the spinal cord. Okay? So I'm not spending, that wasn't really my thing. But, GP, you have a spinal cord there? No, alright. So therefore I will do it then. Well, I'll just show you some things. There's nothing, it's more theory. Spinal cord is not like all these brain slices here. It's very much theory. So what can we see on a spinal cord? What can they ask you? Well, they can ask you this. And what is this covering here? We see fat outside. Okay, so that fat outside of this covering, see a lot of fat out here? Okay, so that covering therefore, that has fat outside of it must be the dura mater. Okay, because outside of the dura will be what? Epidural fat. Okay, what's contained in the epidural fat? The internal vertebral venous plexus. Okay, so in a lumbar puncture, and I advise you to know the anatomy of a lumbar puncture. Okay, that could be a station. There may be a station in the exam marked lumbar puncture. Okay, so we should know all the structures that are traversed, like the skin, the supraspinous ligament, going through the ligamentum flavum. Okay, then going through an endosteal layer. Okay, through the epidural fat, reasonable, through the dura mater, and that's OJP was done many CS lumbar punctures. And then into what? Into the subarachnoid space. What's the largest cistern? Chantal, what is the largest cistern in the human body? I don't know. So what's the largest cistern in the human body? The largest subarachnoid, or let me see, forgive me, wrong thing. Largest subarachnoid space. Or cistern, yes? The lumbar. Isn't that so? Not cisterna magna. Cisterna magna is the largest intracranial one. Okay? The lumbar cistern. What's that cistern? The lumbar cistern. Okay? Alright, so outside here that's dura mater. And inside here we see the arachnoid meter. Okay? The arachnoid meter. And there will also be pia mater. When I need my glasses here, wait a while. My glasses. I have glasses. Do you see them, people? Oh, they're on. My God, terrible. Whoa. Very good. Excellent. Madness, eh? Where are my glasses? I can't go to work without my glasses. Alright, very good. Alright, so relax. What's happening is the lighting is very poor here. Okay? But in the spinal cord, the arachnoid meter is sort of rather thick. Alright, far thicker than you find in the cranial cord. So there's the dura, there's the arachnoid, and clinging on here now is the pia mater. Okay? And we see here, right here, good. Okay, we can go down on it, excellent. And that's one of the 19 to 21 pairs of denticulate ligaments. Okay? So there is one of them right here. Okay, so we can go under it right here, and that's a denticulate ligament. Okay? Now, my colleague, Dr. Ledenkwe, likes to set EMQs on denticulate ligaments. Alright? So make sure you read and read and read everything there is to know about denticulate ligaments. Okay? So they will be formed basically by condensations of pia mater in between the sensory roots and the motor roots of the spinal nerve. 19 to 21 pairs. Is that so? Any more than 20, 19, 21? Any? Yeah, around that number. Okay? From then. Excellent. Okay, then it pierces the arachnoid. Reasonable. Pierces the arachnoid and anchors into the dura. Okay? So it will basically stabilize the spinal cord. Alright? So that you won't get it spinning around inside. Okay? So there's no torsion in the spinal cord. It will stabilize. So remember Dr. Ledenkwe's EMQ on denticulate ligaments. It's very, very exacting. Alright? So remember it's going to give there 19 to about 21 pairs. Have you read more than 21 pairs? Alright. Over about 19 to 21. Okay? They're formed by condensations of the pia mater. I'm trying to create an EMQ for you. Formed by condensations of the pia mater. Okay? Occurring between, arising roughly at the point between the sensory rootlets and the motor rootlets of the spinal nerve. They pass laterally, pierce the arachnoid, anchor into the dura, and basically they're going to prevent, like this here, other than them causing to like that, will prevent the spinal cord from undergoing torsion. Okay, I remember that one EMQ. So no torsion, no spinning of the spinal cord. Okay. Well, anything else about the GP? Anything else about the denticulate ligaments? Okay, so condensations of pia, and remember that pia is also the vascular layer. All right, the pia, the arachnoid meter is avascular, and the pia mater is the vascular layer. Okay, all right. Okay, so know about the denticulate ligaments. Then I remember a question asking whether, and the spinal cord was placed down, whether you're looking at the anterior aspect or the posterior aspect of the spinal cord. Okay, that one I remember. And I can see here that this is just one blood vessel going down in the midline. So this is going to diagnostically tell you that you're looking at the anterior part. Well, the anterior part has the anterior median fissure, and posteriorly there's a posterior median sulcus. So the anterior median fissure, and in that anterior median fissure will travel the anterior spinal artery. So the vertebral arteries will give rise to spinal arteries, and they will unite to form one descending anterior spinal artery. On the posterior part, in relation to the sensory roots, are the posterior spinal arteries. And in every practical, expect a question on artery of Adam Kawinsk. Okay? I've never seen a practical that never had a question on Adam Kawinsk. So from T10. So there are things we must go into that exam. As I see my colleague at the top, I'm sorry to give it away. Crus communis. Doctors reunions. Alright? So I think there is Dr. Crus communis right at the top of there, right? So Crus communis, doctors reunion. nerve supply and lymphatic drainage of every millimeter of the pinna. Alright? So every millimeter of the pinna of the ear, we need to know what's the lymphatic drainage, what's the nerve supply. Everything about Crus Communis, Doctors Reunions, and that park that's beyond Spanish Town. Alright, very good. Alright, so there we see the spinal cord, very good, and that's the anterior spinal artery. Okay, and this is the pia mater. As I said, remember in the spinal cord that the arachnoid mater is thicker, and then outside the dura mater, and then outside we see fat. These are the spinal nerves, and we can see the rootlets. So these, if this is anterior, therefore, these will be the motor rootlets of the spinal nerve. And if we trace it down right here, then always we will see something called, always, we will see the filum terminale. If we spread out everybody here, we'll see right the one that comes down in the center right here, that's the filum terminale. See him right here? He's darker than the rest of them. That's the filum terminale. The filum terminale is right here, a continuation of this part known as the tip there, the conus medullaris. So that's the conus medullaris. Okay? There's a little tiny terminal cistern in the conus medullaris. So the central canal just sort of dilates to give you a little terminal cistern in the conus medullaris here. Then we see the conus medullaris, and the tip of it, remember, is going to be at the intervertebral disc between L1 and L2. L1 and L2. Okay, and in the child it's at L3, and in the old person, because of shrinkage of the intervertebral disc, loss of water from the intervertebral disc, the vertebral canal collapses to a degree, and then it's back down to L3. So it starts at L3, goes to L1, and then in old age back to L3 again, usually. Okay? So there we see now the conus medullaris, and there we see now the going right down. So right back here, that's the cauda equina. Okay, so you may get a question on cauda equina syndrome. What happens when the cauda equina is compressed, etc. Okay, so that's the cauda equina right here. And remember that that filum terminale is going to continue down, pierce the arachnoid, pierce the dura, and going to the formation of a coccygeal ligament, which is going to insert right into the coccyx, the tip of the coccyx. Okay, just right down, so that the filum terminale can be said to go right down to the coccyx. Okay. So where does it? So Kelly Monroe, where does the dural sac close? Kelly Monroe, where does the dural sac close? Where does it, the dural sac close, Kelly Monroe? S2. All right. Seen by the what? On the living subject, how would you identify S2, which is the posterior superior iliac spine? Seen by the dimples, right? You take a little outing to the beach, you will end up seeing a lot of dimples. Kristen told me, and we'll go and make observations. So S2, we're doing a project on S2. All right, very good. So that's the posterior superior iliac spine. All right, end of story with it. So Dr. Laws asked me to show you spinal cord, which I did. All right, so I don't want to take up. So just go through, have fun, and when the time comes to an end, it comes to an end. All right, there. So when we go right down here now, okay. So right here, Chelsea, can we go further in? Excellent. Excellent. Wow, that's excellent. Wow, look at that. So there. So let's get a smaller pinch. Right here. Okay, and we go right into here. Okay, so where's that pin placed in? So that pin is placed in the foramen of Monroe. Okay, that's the foramen of Monroe. Reason of the that's the foramen of Monroe. Okay, so it's described by Alexander Monroe. Okay, and that has boundaries anteriorly formed by the anterior column of the fornix and posteriorly by the anterior nucleus of the thalamus. A connection between lateral ventricle and third ventricle. Reasonable? So we may get a blockage at the foramen of Monro. Will it give you a communicating or a non-communicating hydrocephalus? You get a communicating or non-communicating. So we could develop an EMQ. Surely there's going to be a station marked CSF. Okay, so CSF should be a station. Alright? So you must know everything about CSF. Okay, so we can develop quickly an EMQ about CSF. Produced primarily by the choroid plexus of the lateral ventricle. How much mils produced each day? 500 mils. Turnover rate, 3 to 4 times a day. Okay. Effective weight of the brain in CSF, 50 grams compared to 1.5 kilograms. Reasonable. Function basically to cushion the brain. Reasonable. Alright. Leads through the foramen of Majandi and Lushka. Foramen of Majandi leads into what? Cisterna. Magna. Foramen of Lushka leads into where? Lateral angle cistern. Reasonable. We can get what's called a communicating hydrocephalus and a non-communicating. Foramen of Monro is one side where the CSF may be held up. Another side is at the aqueduct of Sylvius, right here. So right going down there, that's the aqueduct of Sylvius. Okay, sorry, got a little mashed up. The aqueduct of Sylvius coming right down here. Okay, right here, sorry. That's it. In fact, this goes right into the aqueduct. Okay, there. So if I put the probe right in here, forgive me, there you go right into the aqueduct of Sylvius, just like that. See? That's into the aqueduct of Sylvius. Okay? So we can, if these aqueducts, if the foramen of Lushka gets, the foramen of Monro gets blocked, or the foramen of, or the aqueduct of Sylvius, what type of hydrocephalus? It's called non-communicating, because the ventricular system is failing to communicate. Reasonable? Alright? So that's very important. So there we see now, that's the foramen of Monro, and we see a band coming. So that's the caudate nucleus right here, and the thalamus, and right there there's a distinctive band coming right in. Okay, and who is that band that comes right here? That travels in the terminal sulcus, and that's called the stria terminalis. Connects what? The amygdala to the septal area. That's the stria terminalis. Travels with the thalamus striate veins. Okay? So this person had hydrocephalus. Okay? Alright? This person had, you can see the ventricular system is very dilated. Okay? Suspect this would have been a communicating hydrocephalus, something external maybe. Alright, so there we see very, very large. See there we're going into the what? Into the posterior horns of the lateral ventricle. So that's the splenium. And we see this elevation right here, and that elevation is known as the calcar avis. Then we see these structures here. What are these flattened out structures? The crura of the fornix. Alright, that's the crura of the fornix right here on either side, and both of them will unite. Okay, and that's the fornix coming forward here. Okay, so this is a front horizontal section, and there we see the internal capsule with the anterior limb and the posterior limb. That's the thalamus, the head of the caudate nucleus, and just a little bit of the lentiform. And there you can see the two foramen of Monro right here on either side. That's the anterior horn of the lateral ventricle. So that's the head of the caudate nucleus. Okay? So what are some main afferents to the head of the caudate nucleus? Or to the caudate nucleus? What are some main afferents going to the caudate nucleus? Main afferents. Okay? And that's the caudate nucleus is a part of the striatum. Okay? So everything is going to end in striate. Alright? And the most important one we can think of is where the dopamine comes from. So there's nigrostriatal pathways. Nigrostriatal pathways. What are some other pathways? From vast areas of the cortex. So corticostriate, nigrostrial, thalamostrial, and what else? And from the amygdala. Did we say that? Okay. So these are all going into the striatum. Main output of the striatum is to the pallidum, striopallidal pathways. Okay? Alright? What's the blood supply to these structures right around here? Are very, very important. My colleague Dr. Thomas, every practical I've seen, he always loves to ask the artery going to this area right here. What's the name of that artery? Lenticulostriate. Okay, lenticulostriate comes from where? The middle cerebral artery. The lenticulostriate is coming from the middle there. Okay, so there we see here. Okay, now if I put a pin way back here, way back here. All right, where are we? What's that area known as? Far back on the. So I've gone as far back as I could go on. So there we see the superior temporal gyrus, middle temporal gyrus, inferior. So I've gone to the most extreme posterior end of the superior temporal gyrus. So you can't, there's no ambiguity. Okay? So what area is that known as? It's the planum temporale. That area is called what? Planum temporale. And just in front of it is the gyrus of Heschel. Brodmann area is what? 41 and 42, isn't that so? Brodmann area 41 and 42. Okay? Brodmann area 41 and 42. What's the blood supply to the superior temporal gyrus? Middle cerebral. So frontal temporal branches of the middle cerebral artery. Okay? Which nucleus of the thalamus projects here? Which nucleus of the thalamus projects here? MGB. Okay? MGB will project to what? To the primary auditory area. Through what part of the internal capsule? The sublentiform part. Okay? The sublentiform part. What's the blood supply to the sublentiform part? What will supply the sublentiform part? Chantal? Anterior choroidal. Okay, so the anterior choroidal artery is a very important artery. What supplies the optic radiation? So if we get a cerebrovascular accident, what supplies the structure that comes right back here called the optic radiation? And striate branches of the posterior cerebral. Okay? And remember, right at the tip of the occipital lobe, they may ask you about macular sparing. Okay? Macular sparing. Okay? So very, very important. Alright? Now if I were to put up, well, I can put in another one, but let me put in this. This, if I take 3 pins and connect them together, these 3 pins here, I want them to be of the same color. Alright? So these 3 pins, if I were to connect these 3 pins together, what are they outlining? Take another loop. And these are connecting the prefrontal cortices. The forceps minor. Alright? The forceps minor. Coming from the splenium is the forceps major. Alright? Now, what's the main connection? So which nucleus of the thalamus is connecting to the prefrontal cortex? And that's the dorsomedial nucleus. Right? Or the medial nucleus of the thalamus. Okay? The medial nucleus of the thalamus. Alright, leave that alone. Okay. So if we trace, so there is a pineal gland right here. Okay, that's a pineal right here. That's the superior colliculus, the inferior colliculus, and right here that will be the posterior commissure. There we can see the hypothalamic sulcus, very prominent on this brain, and there we can see the anterior commissure. When you trace the fornix around, which is coming from the hippocampus, it will divide into fibers that go above the anterior commissure and fibers that go posterior to the anterior commissure. These fibers that are going above will be called precommissural fibers. So the fornix connects the hippocampus not only into the mammillary body but into the septal area. Okay, that's the septal area. Chantal, what's one of the main outputs of the septal area? the medial forebrain bundle, connecting what to what? Septal area to hypothalamus. Okay? There's another big road that passes through the septal area, right through the hypothalamus, going down into the brainstem. A massive road, big highway, going right through from the septal area, hypothalamus.